Systemic sclerosis is an autoimmune chronic fibrosing disease. Scleroderma mostly affects skin, but also it can cause severe injury to many internal organs in our body. Scleroderma has three major events in pathogenesis. The initial event that triggers disease is injury to the blood vessels. Damage to the blood vessels provokes immune reaction, and whether immune reaction will develop or not depends on individual genetic predisposition. And autoimmune reaction subsequently induce tissue fibrosis. So, to explain the pathogenesis of scleroderma, here we have endothelial cells of the arteriole. Endothelial cells have nucleus, and under the endothelial layer we have subendothelium. And in the subendothelial space we have fibroblast. And the major function of fibroblast is to produce collagen molecules. And collagen molecules form so-called extracellular matrix. Also, in the subendothelium we have macrophages that provide immune defense, and in the blood we have immune cells as T and B lymphocytes. But sometimes some pathogenic factors as infections, drugs or toxins or silica exposure can cause severe injury to endothelial cells. Usually any injury causes inflammation, and also with cellular injury the membrane of endothelial cells becomes disrupted. Inflammation results in the release of massive amount of cytokines into the blood. Cytokines attract T and B lymphocytes. In response to this, T and B lymphocytes enter into the subendothelial space. Also, with disruption of the cellular membrane, intracellular content undergo vacuolization. This process results in formation of vacuolized endothelial cell cytoplasm particles, simply speaking VAC. When VAC appears in the subendothelial space, macrophages immediately phagocyte these particles and present them on the MHC2 receptor to T helpers. The logic is that macrophages provide sort of phase control in tissues. When they see a new molecule, they immediately try to present this molecule to T helpers, and T helper will determine whether it's a normal substance or it's something pathogenic. Normally, if vascular injury occurs, T helpers do not see VAC as antigen, and thereby T helpers do not start immune response. But in individuals that have HLA-DRB1 01 or 04 alleles, inflammation most probably will develop. And to explain why, we have to know how antigen presentation occurs. In normal condition, when VAC are produced, macrophages intakes VAC in order to present this particle to T helper. And antigen presentation occurs by an MHC2 receptor. What we have to know about MHC2 receptor is that it's a protein, and the genetic information that tells us how to make MHC2 receptor is contained in the gene that is located on chromosome 6, and we call this gene HLA-DRB1. But we have different variations of HLA-DRB1 genes, and such variations we call alleles. The simplest analogy is the eye color. You see, we all have genes that encodes the color of our eyes, but some of us have blue eyes and some of us have black eyes. And in this case, genes that encodes blue eyes we call blue allele, and genes that encodes black eyes we call black allele. So we all have genes that encodes eye color, but this gene can be different, and different variations which are blue and black colors of the same gene that in this case encodes eyes we call alleles. So in case of scleroderma, we all have genes that encodes MHC2 receptor. We call this gene HLA-DRB1, but this gene can be different, and different variations of HLA-DRB1 gene we call HLA-DRB1 alleles. For example, if person has HLA-DRB1 03 allele, this person will have MHC2 receptor that was made based on genetic information in HLA-DRB1 03 allele. And such MHC2 receptor presents particle in a perfectly normal way. And when T helper income to this receptor, they recognize VAC as a normal substance. and because of this, they do not see any danger. If person has HLA-DRB107 allele, this person will have MHC2 receptor that was made based on genetic information in HLA-DRB107 allele. And such MHC2 receptor presents VAC also in a perfectly normal way. Thereby, there will be no inflammatory response. But some individuals have HLA-DRB101 allele. Thereby, in this case, person will have MHC2 receptor that was made based on genetic information in HLA-DRB101 allele. The problem is that this particular MHC2 receptor do not know how to present VAC to T helpers. When T helpers income to MHC2 receptor, in this case, because particle is presented in abnormal way, they cannot recognize this particle, and thereby they think that it's antigen. And also, if person has HLA-DRB104 allele, MHC2 receptor that was made based on genetic information in HLA-DRB104 allele also do not know how to present VAC, and because this particle is presented to T helpers in abnormal way, T helpers recognize VAC as antigen. In response to any antigen, T helpers immediately becomes activated, and subsequently they activate B lymphocytes. With activation, B lymphocytes begin to produce antibodies, and also T helpers activate tissue macrophages. So in individuals that have HLA-DRB101 and 04 alleles, MHC2 receptor presents cytoplasmic particles in abnormal way, and because of this, T helpers recognize VAC as antigen. So in response to antigen, T helpers becomes activated. Once T helper becomes activated, T helper by production of interleukin-6 activates B lymphocytes. Once B lymphocytes becomes activated, they begin to produce antibodies against nuclear material in VAC. The reason is that nuclear material is the most immunogenic. In normal condition, nuclear material is contained inside the cell under the nuclear membrane. So immune cells usually do not see anything nuclear around them. But with endothelial injury, now nuclear material becomes exposed. And everything unusual for immune cells automatically becomes antigen. First of all, B lymphocytes produce antibodies against topoisomerase 1. Also, B lymphocytes produce antibodies against centromere, and also they produce antibodies against RNA polymerase 3. Antibodies are quite reactive substances. They can cause direct damage to tissues, but also they can activate fibroblasts. In addition to this, B lymphocytes, by production of transforming growth factor beta, can also directly activate fibroblasts. Another cells that T helper activate are tissue macrophages. Once macrophages becomes activated, they begin to produce transforming growth factor beta, interferon gamma, platelet-derived growth factor, and interleukin-13. All of them activate fibroblasts. This massive stimulation of fibroblast results in their activation. With activation, fibroblast transforms into myofibroblast. And myofibroblasts have two superpowers. They have incredibly strong contractility and they produce enormous amount of collagen. So once fibroblast becomes myofibroblast, the production of collagen into extracellular matrix significantly increases, and this results in excessive production of extracellular matrix with very high concentration of collagen. So extracellular matrix becomes incredibly dense, and also because collagen is a major component of extracellular matrix, with increasing amount of collagen, the amount of extracellular matrix increase. So in scleroderma, we have two major pathogenic factors. It's myofibroblast, excessive production of extracellular matrix with high concentration of collagen, activated T and B lymphocytes, and autoantibodies. The major tissue that becomes affected in scleroderma is skin, because skin is the most dependent tissue on collagen production. Skin has two major components, it's derma and vasculature. In derma, excessive deposition of extracellular matrix with high concentration of collagen greatly increase skin thickness. Increase in facial skin thickness cause formation of so-called purse-string mouths. Here we see images of patients with scleroderma. As we see, they have very tight skin. And interesting that on extremities they usually do not have hair due to the skin atrophy. And this is how purse-string mouth looks like. Increase in skin thickness on toes and fingers cause formation of so-called puffy fingers. Puffy means basically edema. And with time, thickness of toes and fingers increase even further, and this causes sclerodactyly. Here we see hands of patients with scleroderma. On first image, we see puffy hands as the initial phase in scleroderma progression. Then puffy hands progress to sclerodactyly, and with sclerodactyly, progressive skin atrophy develops. Initially, it's mild atrophic changes, but with time, severe atrophy develops. Infiltration of derma by activated T and B lymphocytes provokes tissue inflammation, and after inflammation, regeneration occurs. And during regeneration, calcium binds to exposed collagen molecules in the derma. We call this process saponification. So with each inflammation, the amount of calcium molecules in the derma increase. And deposition of calcium in the derma forms skin nodules. We call this condition calcinosis cutis, which is basically nodules under the skin. So to explain this, here we see extracellular matrix, which is composed mostly of collagen. And also there is tissue membrane, and there are some calcium molecules that circulate in the bloodstream. Normally, calcium do not interact with tissue. But once inflammation inside the tissue occurs, tissue membrane becomes disrupted. Also, inflammation creates acidic pH inside the tissue. Because tissue membrane becomes disrupted, now calcium can enter into the tissue. And because with inflammation tissue has acidic environment, acidic pH provokes calcium precipitation inside the tissue. And when calcium precipitate, it's practically impossible to remove calcium from the tissue. Then regeneration occurs, but precipitated calcium remains in the tissue. Then again inflammation occurs, membrane becomes disrupted, and acidic pH provokes calcium precipitation. And then again regeneration occurs. So with each inflammation, calcium molecules progressively accumulate in the tissue. And the accumulation of calcium results in formation of a nodule under the skin. Exactly this state we call calcinosis cutis. Here we see a real-life image of calcinosis. This mass is precipitated calcium. Also we can determine calcinosis on X-ray, and on the last image we see severe calcinosis of the digits. On this image we again see patient with scleroderma. As we see, skin is very tight, and on hands there is practically no hair. Such edematous hands we call sclerodactyly. Also, we see again patient with very tight skin, but in addition to this, here we see multiple telangiectasia, which is also one of the manifestations of scleroderma. Also in scleroderma, patients usually have dilated nail fall capillaries. We will see why a little bit later. And here we see massive deposition of calcium in the skin, that in this case even cause ulcers. The second component of the skin is vasculature. Excessive deposition of extracellular matrix cause compression of the blood vessels. With compression, blood flow decreases, so hypoxia develops. And the most sensitive region to hypoxia are peripheral tissues, as fingers or toes. To explain this, here we have a blood vessel through which blood flow occurs. Blood vessel is composed of endothelium and subendothelium. We require blood flow to deliver nutrients and oxygen to the tissues. Blood flow is equal to pressure difference between two regions divided on resistance between them. And resistance is inversely proportional to the force power of radius. So in normal condition, blood flow delivers sufficient amount of nutrients to supply all cells and various tissues in our body. But if scleroderma develops and the amount of extracellular matrix increases, it creates a problem because extracellular matrix overgrowth causes significant decrease in the lumen of the blood vessel. So scleroderma causes decrease in radius of the blood vessel, with decrease in radius resistance increase, and with increase in resistance blood flow decrease. So now with decrease in blood flow, the delivery of oxygen and nutrients decrease. This creates ischemia in peripheral tissues, because now there is not enough oxygen and nutrients for all cells. So in some cells ischemia develops. Prolonged ischemia causes cellular death, and with progressive death of cells, ulcers and scars develops. First of all, a decrease in blood flow into capillaries causes loss of capillaries. In response to loss of capillaries, remaining capillaries enlarge. So this combination of loss of capillaries and enlargement of capillaries creates an abnormal nail fold pattern. Also, with decrease in blood flow, the delivery of oxygen and nutrients decrease, so ischemia develops. And the most severe ischemia develops in the most peripheral regions, as digits. As a result, ulcers develop. And also, this causes formation of a so-called pitting scars on the fingertips. So here we can see active digital ulcer. And also we can see a cyanotic finger. Obviously, cyanosis is caused by decrease in blood flow to the finger. In this case, it's a cyanotic phase of Raynaud phenomenon. In response to hypoxia, postcapillary venules react with vasodilation. And vasodilation of postcapillary venules causes formation of telangiectasia. Here we see multiple telangiectasia on lips, and here we can see them more closely. So basically, telangiectasia is formed simply by severe vasodilation of capillaries and venules. Also, the amount of myofibroblast in the blood vessel wall increase. And even in normal condition, decrease in temperature or severe emotional stress can provoke vasoconstriction. But because in scleroderma the amount of myofibroblast is significantly higher than normal, and as we know, one of the superpowers of myofibroblast is their ability to constrict, now with increasing amount of myofibroblast, the contractility of the blood vessel wall becomes significantly higher than normal. So in case of scleroderma, vasoconstriction is much more severe. Severe vasoconstriction causes decrease in blood flow to the tissues, especially to peripheral tissues as digits. And decrease in blood income causes ischemia. Initially, pallor develops, then pallor is changed by cyanosis, and after the cyanosis, when vasoconstriction is gone and blood begins to inflow again, redness develops. And red fingers and toes is the final stage. Overall, this pathological feature of scleroderma we call Raynaud phenomenon. Here we see how Raynaud phenomenon looks in real life. So on some fingers we see pallor, and on other fingers we see cyanosis, which are simply different stages of the same pathological phenomenon. And interesting that thumb is not affected. On this image we see different nail fold capillaries patterns. On first image we see Raynaud phenomenon, where we see hairpin capillaries. On the second image we see scleroderma. In this case there is giant capillaries. On third image we see dermatomyositis with bushy capillaries. And on the last image we see cold challenge, which is the test for Raynaud phenomenon. The point is that we put hands into the cold environment, and by this we provoke vasoconstriction. And then we put hands into the environment with normal temperature. And now we observe how the temperature of the hands changes. In normal condition, hands should come back to normal state with temperature over 35. But in Raynaud phenomenon, hands remain cold, because vasoconstriction was so severe that blood vessels cannot relax. So by cold challenge we can diagnose Raynaud phenomenon, which is very helpful. Important that scleroderma affects not only skin, but also it can cause severe damage to internal organs. First of all, in the lungs, excessive deposition of extracellular matrix, which is in fact connective tissue, cause pulmonary fibrosis. Pulmonary fibrosis causes decrease in total lung capacity, which in turn causes decrease in income of oxygen into the blood. Decrease in oxygen concentration in the blood we call hypoxemia. In response to hypoxemia, pulmonary vessels contract, and contraction of pulmonary vessels causes pulmonary hypertension. Pulmonary hypertension greatly increases the load on right ventricle, which causes right ventricle hypertrophy. And after the right ventricle, with time, hypertrophy of the left ventricle will develop. So with time, pulmonary hypertension will cause heart failure. In the esophagus, autoantibodies and activated T and B lymphocytes cause severe damage to smooth muscle cells of the esophagus wall. In addition to this, inside the esophagus wall, systemic sclerosis will cause excessive deposition of connective tissue. All of this combined cause severe GI dysmotility, and decrease in gastrointestinal motility cause GERD and dysphagia. In the kidneys, autoantibodies, together with activated T and B lymphocytes, cause severe damage to smooth muscle cells of the arterioles. And also, in kidney tissue, scleroderma induce excessive deposition of connective tissue. All this combined cause severe proliferative vasculopathy, which leads to a glomerular ischemia. In response to glomerular ischemia, kidneys activate renin-angiotensin-aldosterone system. Hyperactivation of RAS system with time causes renal crisis, which manifests with really severe hypertension. We call this state malignant hypertension. Here we see that most commonly scleroderma affects skin. It causes skin fibrosis, calcinosis, telangiectasia, ulcers, and Raynaud phenomenon. Less commonly, scleroderma affects internal organs. It can be lungs, heart, muscles, or kidneys. But most commonly, scleroderma affects esophagus, and usually damage to esophagus manifests as GERD. On the second image, we see scleroderma-induced lung injury. On this CT, we see ground glass opacities, which is basically extensive fibrosis, and also we see traction bronchiectasis. These changes, combined with decrease in ventilation of the lungs due to a fibrosis, greatly increase the risk of pneumonia. We have two forms of systemic sclerosis. Scleroderma can be diffuse, which is the worst scenario, or limited, and limited form has a better prognosis. Limited form most commonly affects skin and vasculature. We call this form limited because typically it affects skin and internal organs are not the major targets. Actually, limited form, also known as CRESS syndrome, which is really easy to memorize. C stands for calcinosis. In limited form, scleroderma usually affects head and distal part of the upper extremities. Distal part is important here because diffuse form affects whole upper extremities. So the first criteria is deposition of calcium in the skin, which is calcinosis cutis. R stands for Raynaud's phenomenon, and Raynaud's phenomenon is a skin manifestation caused by injury to the blood vessel wall. E stands for esophageal dysmotility. Esophageal dysmotility is caused by deposition of connective tissue in esophageal wall, and typically it manifests as GERD. S stands for sclerodactyly. Sclerodactyly is caused by excessive deposition of connective tissue on fingers and toes, so it's a skin manifestation. And T stands for telangiectasia. Telangiectasia are caused by vascular injury. So as we see, except esophageal dysmotility, all these criteria are related to skin, and most of them are caused by vascular injury. There are practically no systemic involvement. The specific marker of CRESS syndrome is significant elevation in anticentromere antibodies. Increase in anticentromere antibodies is the major diagnostic feature of CRESS syndrome. And as we said, limited form has a better prognosis. Diffuse form also affects skin, but important that diffuse form usually affects skin on trunk and whole upper extremities, not only distal part of upper extremities. But most important that it causes severe injury to internal organs. First of all, it causes damage to renal tissue, which leads to a renal crisis. So scleroderma induces hyperactivation of RAS system, and hyperactivation of renin-aldosterone-angiotensin system typically manifests as a renal crisis with malignant hypertension. Also, scleroderma causes myocardial injury, typically it's myocardial fibrosis, and also scleroderma causes lung fibrosis. So in systemic sclerosis, most commonly pulmonary fibrosis develops that leads to a pulmonary hypertension and heart failure. And in addition to this, if myocardial fibrosis develops, it can greatly accelerate heart decompensation. The specific diagnostic markers of diffuse scleroderma are anti-topoisomerase I antibodies, also called anti-SCL70 antibodies, and anti-RNA polymerase III antibodies. So increase in both anti-RNA polymerase III antibodies and anti-topoisomerase I antibodies are specific markers for diffuse scleroderma, and because diffuse form causes severe injury to internal organs, it has a worse prognosis. In clinical medicine, we use so-called diagnostic criteria, which is basically a summary of what we have discussed. First of all, it's sclerodactyly or puffy fingers. So the first criteria is related to skin injury, and the most prominent feature of the skin injury is puffy fingers or sclerodactyly. The second criteria is ulcers on the fingertips. The third criteria are telangiectasia, and the fourth criteria is abnormal nail fold capillary pattern. We can group them because both ulcers, telangiectasias, abnormal nail fold capillary pattern are caused by local hypoxia due to the vascular injury. The fifth criteria is pulmonary hypertension or interstitial disease. So as we know, pulmonary fibrosis, which is interstitial lung disease, with time causes pulmonary hypertension. So both pulmonary hypertension and pulmonary fibrosis are the criteria for systemic sclerosis. The next criteria is Raynaud's phenomenon. It's one of the most specific features of systemic sclerosis. And Raynaud phenomenon is related to skin manifestations and is caused by vascular injury. The seventh criteria is the group of criteria that are related to antibodies. Basically, it's a diagnostic markers. As we know, there are three most common antibodies in scleroderma. It's anti-centromere antibodies, anti-topoisomerase I antibodies, and anti-RNA polymerase III antibodies. And a score higher than 9 permits us to make a diagnosis of systemic sclerosis. For treatment of systemic sclerosis, we use immune suppressive drugs, as cyclophosphamide, mycophenolate mofetil, and methotrexate. All of them are non-selective. All of them, by suppression of immune system, decrease the severity of inflammation. What we have to know is that cyclophosphamide is the optimal choice in cases when scleroderma causes severe lung fibrosis, and methotrexate is very good in cases with severe skin injury. All other drugs are used for symptomatic treatment. First of all, we use proton pump inhibitors in cases when systemic sclerosis provokes GERD. As we know, one of the most common manifestations of systemic sclerosis is GI dysmotility, and dysmotility can provoke GERD. To decrease the severity of GERD, we use proton pump inhibitors, as omeprazole or lansoprazole. Also, we can use angiotensin-converting enzyme inhibitors, in cases when systemic sclerosis causes renal crisis. As we know, scleroderma affects kidney tissue, and damage to kidneys causes hyperactivation of renin-angiotensin-aldosterone system. Overactivation of RAS leads to renal crisis with malignant hypertension. So to prevent this, we should inhibit RAS system, and for this purpose we use ACE inhibitors, as ramipril or captopril. Also, we can use selective phosphodiesterase 5 inhibitors, in cases when systemic sclerosis causes pulmonary hypertension or digital ulcers. Basically, selective phosphodiesterase 5 inhibitors, as sildenafil or tadalafil, cause significant vasodilation, and vasodilation causes increase in blood flow, thereby more nutrients and oxygen income to tissues, and this can prevent formation of ulcers or pitting scars. Also, because of vasodilation, sildenafil is very effective in pulmonary hypertension. And for Raynaud phenomenon, the first option are peripheral calcium blockers. We call them DPINs. It's amlodipine or nifedipine. Peripheral calcium blockers, as amlodipine, cause relaxation of smooth muscle cells. As a result, they decrease the severity of vasoconstriction. So with amlodipine, vessel dilate, reduce increase, and thereby blood flow increase. So ischemia becomes less severe. As a result, the symptoms of Raynaud phenomenon also becomes less severe.